Today we will be discussing about acute flaccid paralysis surveillance. The name of the topic itself gives lot of clue about what it constitutes. So acute means something that is sudden in onset. Flaccid means a flappy muscle which is usually due to loss of bone. Then paralysis means weakness of muscles or movement. Surveillance means constant monitoring and reporting. Constant monitoring and reporting. Okay. So this is what we are going to see today. Okay. So this is usually done for polio. Okay. So this is what we are going to see today. So why do we need to do this for polio? See, the fundamental concept for doing this is very simple. If you want to find out whether somebody is an alcoholic or not, it is very simple. Okay, so you just do a couple of tests and find out that whether he is an alcoholic or not. But if you wanted to confidently say that this person is not an alcoholic, it is not that easy as you may presume. You might need to do a surveillance where you need to constantly monitor him and do keep him under surveillance for a considerable number of days, then only you can certify that the person is a non-alcoholic. So similarly, if you wanted to say India has yes, n number of polio cases, or for that matter, any particular country has this much number of cases, it is quite easy to do so. But if you wanted to say that there is zero polio case, and this country has been maintaining that zero polio case, then you need to do this surveillance. Okay. So what is this acute flaccid paralysis? So anything, as the name itself suggests, anything which is sudden in onset, resulting due to reduced tone, that is flappiness, because of which there is a weakness and paralysis with one or more limbs. That is what we call it as acute flaccid paralysis. One of the most important thing to remember is there is no sensory loss. Sensory uh, sensation remains intact. This is the epidemiological definition given by the WHO. Okay, so here WHO states that any AFP in a child, AFP is you should suspect anything in a child with less than 15 years of age, where there is a suspect, or if you can suspect a poliomyelitis at any age. Okay, so if there is any sudden onset or weakness that is reported in any child with less than 15 years of age, that is both male and female child, or if there is a suspect for poliomyelitis at any age, then you have to do an AFP surveillance to the system. So what are the clinical features? There is a sudden flaccid weakness followed by diminished tone and reflexes. And in case of polio, the sensory system remains intact and there is asymmetry. That is, both the limbs are unequally involved. Okay, one limb may be more affected than other limb. So that is what this asymmetry means. Okay. Whereas in case of other things like GBS, that is Guillain-Barré Syndrome, there is a symmetry. In case of AFP, there can be cranial or respiratory involvement also. So coming to the differential diagnosis, one is poliomyelitis, which is very common. I'm just listing out the common differential diagnosis. The other one is Guillain-Barré syndrome, then transverse myelitis, then botulism toxin, and then hypokalemic paralysis. Okay. So in case of botulism, there will be descending paralysis, whereas in case of GBS, there will be ascending paralysis plus symmetrical involvement will be there. In case of transverse myelitis, there will be bilateral paralysis associated with a sensory loss. And in case of hypokalemia, there will be an episodic reversible weakness. Okay, to sum it up, these are all the differential diagnosis: poliomyelitis and enterovirus 71, GBS, diphtheric neuropathy, transverse myelitis, botulinum toxin, myasthenia gravis, hypokalemic paralysis, myositis. In addition to that, there can be also traumatic neuritis. So, what will be the characteristics of these things? So, in case of poliomyelitis, there will be asymmetric paralysis associated with no sensory loss, symmetric ascending paralysis, as well as areflexia will be present in diphtheria neuropathy. In case of transverse myelitis, there will be bilateral paralysis associated with a sensory or bladder symptoms. Myasthenia gravis, there will be descending paralysis associated with cranial nerve involvement. In case of hypokalemia, there will be generalized weakness with rapid recovery. Now coming to the neuroanatomical classification, okay, where the level of lesions will be. Okay, so this can be much appreciated when we correlate with here. Okay, so Acute transverse myelitis will be present when there is a lesion in the spinal cord segmentation level. In case of poliomyelitis and intervirus, the lesion will be at the level of anterior horn. Okay, and in case of peripheral nerve involvement, there will be Guillain-Barré syndrome. In case of neuromuscular junction, okay, so there you will see myasthenia gravis, botulism toxin, tetanus, and other agents. In case of muscle fibers, okay, you will see this in toxic myopathy, myositis, as well as myopathy. Okay, so these are all the regions where you will see the acute neuroanatomical issues. Now coming to the need for surveillance. As I have previously said about the alcohol issue, okay, where it is easier to brand someone alcoholic just by catching up when he was going to the bar, but to brand someone as non-alcoholic, or to put it in other words, to certify someone as non-alcoholic, you need to do a surveillance. Similarly, to certify, as well as not just for the certification of non-alcoholic, but also for someone who intends to quit alcohol, who wants to know what is the kind of addiction that he has, even then also surveillance is quite useful. Similarly, surveillance is quite a continuous and systematic health data collection. It acts as the eyes and ears of the public health system. It is useful for detecting the outbreaks early, preventing the spread, and also useful in guiding the response. So, for polio, AFP surveillance forms the backbone, and it is one of the initiative of the Global Polio Eradication Initiative. So there are different types of surveillance actually. So one is a passive surveillance which we do in routine reporting from health centers. For this, whenever we tend to report health systems reported data through programs like IDSP, which is now called as IHIP, we call it as a passive surveillance. Okay, where there is no active case finding, whatever the cases that is being reported to the health system are being reported back. In case of active surveillance, there will be field visited to search for any cases. If suppose there was a, let's say, any notifiable disease outbreak like tuberculosis or Nipah virus, there will be active case finding or door-to-door survey. Then sentinel surveillance, wherein selected hospitals will monitor the disease trends. This you can take up in case of cancer cases. Okay, so where there is a sentinel surveillance, even HIV is also sentinelly done. Surveillance is done sentinelly because you tend to see AN mothers are tested, antenatal pregnant mothers are tested for HIV, HBsAg, and VDRL routinely. Okay, so they are tested for HIV, HBsAg, and VDRL routinely. So these are all done as a part of sentinel cases. Then there is zero reporting. Okay, this is done in case of AFP cases. Even if you tend to see zero cases of acute sudden onset of weakness, you have to report that you didn't get any cases from health system. So that is what we call it as zero reporting. And in case of polio, we do something called environmental surveillance, which we will see in detail, where there will be sewage testing for polio virus, because polio is transmitted through fecal-oral route. So there is a possibility that polio is transmitted through stools, and these stools were present in the sewage, and you test the sewage for detection of any active polio virus. Okay, so that is another type of surveillance which is called as environmental surveillance. Now coming to the AFP surveillance. So it is the gold standard for detecting any case of poliomyelitis. There are four steps involved. The first step is finding and reporting children with acute flaccid paralysis. How do you find those children? So by doing a passive surveillance. Okay, so whenever a child less than 15 years of age reports to you with a sudden onset of weakness in the lower limbs, you should not necessarily lower limbs, a sudden onset of weakness without any sensory involvement, you should have a high suspicion, and you should initiate the collection of stool samples as well as transporting those collected stools for analysis. Then after that, if in turn this turns out to be positive, then isolating and identifying the poliovirus inside the laboratory has to be done. And once this is done, we have to map the virus to determine the origin of the viral strain. So how it is being done, we'll see subsequently. So the flowchart includes you tend to see a case with AFP type illness in less than 15 years of age. Report the case within 24 hours to the health ministry. Okay. So once you report this to the health ministry will in turn ask you to start the investigation. Okay, so you have to collect the first stool sample within 48 hours. Then the second stool sample has to be collected within 2 weeks. Okay, so you collect basically two samples. So one sample at the end of within 2 days, the another sample within 2 weeks. So this has to be collected, and the sample that has been collected has to be transported. It has to be transported. This transportation we call it as a reverse cold chain. Okay, where the sample will flow from field to the lab. Okay, unlike in case of vaccination, unlike in case of vaccination, where you will see transportation from pharmacy to or deep freezers to field. Okay, so this is what we call it as cold chain, and this we call it as reverse cold chain. Okay, then in the lab we will test for isolation, and after that for 60 days we have to do a follow for any residential paralysis. Now, how are we going to what are we going to do with the sample that is collected after 2 days and after 2 weeks? So the sample are sent to laboratories that are accredited by the WHO. Currently, there are 146 laboratories in the world. Okay, and in India, there are selected laboratories. In that laboratory, they will check for wild polio virus, vaccine-derived polio virus, and then non-polio enterovirus. Okay, so these are the things that it will be checked. Okay, in the lab. So as far as reverse cold chain is concerned, this is done so as to maintain viral viability. Okay, just because a virus is present in the stool, usually it is present in the field. If the 146 laboratories that are present in most of the cities or district headquarters or the state headquarters, at least not even district headquarters. So while for transportation it might take 24 to 72 hours. During that time, there is a high chance that the polio virus, if at all it was present, there is a chance that the polio virus that is present there might have died. Okay, so in order to prevent the viability of the virus, we have to maintain it in reverse cold chain, wherein the samples are transported at 4 to 8 degrees Celsius in vaccine carriers with ice packs. Okay, if you are not using it, there is a high chance that there will be a loss of diagnostic accuracy. We call it as reverse because the thing happens from field to lab. Now, the 60 days follow up. So after getting the samples, even if it turns out to be negative, okay, there is no chance of polio virus being there for any of these three, wild polio virus, vaccine derived virus, or non-polio enterovirus. Still, we are supposed to do a follow for 60 days and check for any residual paralysis, death, or full recovery, and it has to be reported. Okay, and then it is useful in confirming the classification whether it is due to polio or non-polio causes. Okay, if suppose that samples that turns out to be positive, what are the things we are supposed to do? Okay, so in general, 99.999% of the samples that are being sent turns out to be negative only. But for that 0.001% positive cases, we have to be so alert. Remember, even a single case of polio case anywhere in the world is threat to everywhere in the country. Okay, everywhere in the world. Okay, so whenever a AFP case test positive for poliovirus, immediately public health response is initiated to prevent a further transmission. So how it is being done? The case confirmed polio is investigated thoroughly by the National Polio Surveillance Project team, and district health officials are involved. The immediate notification is sent to the Ministry of Health, WHO, and local authorities. Followed by there will be house to house search for any symptoms similar to AFP. Okay, so in the surrounding community to identify any potential identifiable cases for children. Remember, the initial case of surveillance only when a child with less than 15 years of age reaches the health system. Okay, so there could be a possibility of other children might have such symptoms, but they do not reach so. Then the stool sample of contacts. Okay, so not necessarily that you have to take stool sample for everyone, but for close household contacts and the neighborhood contacts. Especially in all the children under the age of 5 are collected, and they are again tested for poliovirus for checking if there is any silent transmission. After that, there should be an intensive polio vaccination campaign organized in the area as well as neighboring district, where every children under the age of 5, irrespective of their previous vaccination status, is given OPV. Then environmental surveillance also has to be carried out. Okay, all the sewage sampling in the nearby affected area has to be checked, and sample again has to be sent to the nearest WHO accredited laboratory. Then the follow up has to be done whether there is any recovery is there, residual paralysis there, or if there is any complication is there, and it has to be documented, and feedback and the lessons learned has to be sent. Now, how do we know that whether the program that we do run, whether our surveillance is good or not? In general, for every 1 lakh sample that is tested, at least two or more samples, it will turn out positive for non-polio AFP, the kind of differential diagnosis that we discussed. It could be either GBS, rheumatic neuritis, or transverse myelitis, or myositis, or it could be due to myasthenia gravis. It has to be greater than or equal to 2 for every 1 lakh samples. If it is not the case, then we are not getting the correct sample. Then the stool it's collected should be greater than 80% adequacy. This is about the reverse cold chain. Okay. So if the reverse cold chain fails, the stool consistency might be lost. Then timely investigation. Okay. So how faster we are processing? It has to be processed within 24 hours. Okay. So at least 80% of the cases should be processed within 24 hours, and greater than 80% of the cases should be followed for a period of 60 days. Then there should be an environmental surveillance for detecting any silent transmission. Now, how do we do environmental surveillance? So, we have selected designated sewage sampling units in Delhi, Mumbai, Kolkata, Chennai, Patna, and Hyderabad. Remember, this is independent of any active cases. Okay, so this surveillance is being done routinely, independent of whether any cases are being reported or not. Then, now why this AFP holds such an importance? It is useful in detecting early virus circulation, confirms interruption of transmission, and enables targeted immunization drives. And also, it is useful for giving certificates to countries by WHO. So this is such a useful surveillance system. Okay, and another important thing is it is useful to strengthen the pre-existing surveillance network. And once you establish a network of laboratories as well as field workers, you can train them for doing surveillance for other diseases like measles, rubella, or Japanese encephalitis. Remember, for example, in measles or rubella, you just need to take throat swabs. So instead of a stool sample, you just need to insert throat swabs inside that vaccine carrier, transport that vaccine carrier from the field to the lab. Okay, so it is useful in expanding the surveillance network for other diseases also. Okay, so that is the usefulness. Coming to the India's journey, we started vaccinating for polio in 1995. The polio surveillance started in 1997, and in 2011, the last case was reported in West Bengal. And for 3 consecutive years, we reported zero cases by this AFP surveillance, wherein stool samples were tested routinely. And then India was certified by WHO as polio free. And till today, in 2025, we are maintaining this standard. And this is the certificate we received in 2014. Now, to summarize, surveillance is the cornerstone of disease eradication. AFP surveillance safeguards a polio-free status by detecting every case of sudden paralysis in children. Doesn't matter whichever case it can be. Even one missed case could mean silent circulation of the virus in the community, which can cause drastic consequences. And any case of AFP does not mean that it is always a polio. We have to make sure and look for other differential diagnosis, and we have to remember something called a reverse cold chain, which facilitates. Remember, whether there is zero polio case or 100 polio case, we have to maintain the public health vigilance, and it must continue. Okay, so thank you. Hope you have learned from this one.